Good afternoon to everyone. I would like to welcome everyone. Today we have clinical trend round will be presented by Department of Medicine Unit 3. And the title of trend round is HIV Care at AIIMS, Experience Gained So Far and the Way Forward. We are going to present this CGR in the following heading: the overview of HIV and NACO. ART Center at AIIMS New Delhi will be presented by Dr. Niranjan. Data from our ART Center, opportunistic infection and post-exposure prophylaxis, and then ART resistance and future prospects. I would like to invite first to Dr. Niranjan for his presentation. Thank you.
Thank you, sir. Good afternoon to everyone. So, Unit 3 Medicine, we are going to be talking about the HIV care that's being provided at our ART Center. So I'll start off with HIV epidemiology. So HIV was first diagnosed in the US in 1981. It was first detected in India in 1985-86. Since then, it has spread all over the world and become a global pandemic. It's been raging for past 40 years now. Thankfully, India it still remains in the low prevalence country with 0.22% prevalence. I'll be talking about that subsequently. So if you look at the numbers around the world, there are nearly 37.7 million people living with HIV as of now, as of 2020. Of which 1.7 million are children, and nearly 1.5 million new cases were detected in the year 2020, and nearly 680,000 people lost their lives due to HIV-related causes in 2020. So, if you look at the Indian scenario, the prevalence of HIV in India is 0.22%, with nearly 23.5 lakh people living with HIV in India. However, the good news is that there has been a declining trend in the infections as well as the AIDS-related deaths since 2010. So there's been a decline of around 37% in new HIV infections and a decline of 66% in AIDS-related deaths since 2010. These are as per the India HIV estimates of 2019. So if you look at the trend of HIV prevalence in India, so starting off from 1985 when the first case was diagnosed, so there was a steady rise, reached a peak sometime in the late 90s and early 2000s. And then after that, there's been a steady decline tapering off towards 2019. If you look at state-wise data, the northeastern states of Mizoram, Nagaland, and Manipur occupy the top 3 slots with high prevalence of around 2.3% in Mizoram, and Delhi comes within the top 10 in the country with a prevalence of 0.41. So, if you look at the incidence of HIV, that also has shown a declining trend since 1990s, and especially over the past decade, there has been a significant decline in new HIV infections detected in India. So there's been a 37% decline over the past decade. As well as a state-wise breakup, again the northeastern states of Mizoram, Nagaland, and Manipur occupy the top spots, with Delhi still within the top 10 in the country with an incidence of 0.15 per thousand uninfected population. So looking at the HIV mortality trends, they also mirror the other two trends. There was a peak in HIV mortality in the 2000s, late 90s and 2000s, and that has been declining now with the availability of good ART and good adherence to therapy, and that has been tapering off. As far as the state-wise breakup is concerned, again the northeastern states of Manipur and Mizoram occupy the top slots, whereas Delhi comes within the top 15 in the country with a mortality of 5.21 per 100,000 population. So overall, there's been a 66% decline over the past decade in AIDS-related deaths. So both of these are good news for us. As far as the control of AIDS in India is concerned, the National AIDS Control Organization is at the helm of affairs, and it runs the National AIDS Control Program, and they release periodic guidelines with regards to antiretroviral therapy as well as this statistics, the hard data of AIDS patients in India. So the NACO has set up 553 ART centers all across the country as of now, which are fundamental to the service delivery mechanism. They've also tried to decentralize these services by creating link ART centers and LAC plus centers, of which there are more than double that of ART centers, 1,300 centers odd. And they have created centers of excellence, 11 for adult and 7 for pediatric HIV, and also set up ART plus centers, of which there are 93, and AIIMS is also, the ART center at AIIMS is also one of these ART plus centers. As of March 2020, there are nearly 15 lakh people living with HIV in India who are on ART, including nearly 14 lakh who are availing free lifelong ART from these ART centers. Something significant happened in 2017 when the NACO and the government of India released the test and treat model for HIV. That is, putting HIV patients on ART as soon as they are diagnosed with HIV positive, irrespective of their CD4 count. Also, at the same time, NACO launched the Mission Sampark on 1st December 2017, and the aim of this Mission Sampark was to trace the individuals who were lost to follow-up and bring them back under the ART services. So, as per the latest data is concerned, there are nearly 2 lakh people living with HIV who are lost to follow-up, and efforts are being made to bring them back into the fold. Looking at the HIV prevalence among different population groups, the injection drug abusers and the transgender people occupy the top 2 slots as far as the breakup of populations of groups is concerned. As far as the route of transmission is concerned, 83% of transmission in India occurs through heterosexual intercourse. That is the topmost mode of transmission in India as of now. The other modes such as blood transfusion, infected syringe, parent to child occupy significantly lesser fractions of this amount. When it comes to antiretroviral therapy, so we have multiple goals of therapy, starting with the clinical goals where we aim to improve the quality of life and prolong the life of the patient. Also try to achieve a sustained reduction in the viral load and try to attain immune reconstitution in these patients. And the therapeutic goal refers to achieving all the above 3 at the same time limiting drug toxicity and facilitating drug adherence. And overall, we aim to prevent the HIV transmission in the society by suppressing the viral load and thereby helping end this pandemic. When it comes to antiretroviral drugs, there are several classes of drugs which have come and gone, but currently this is the latest set of drugs which we are using. Of the ones which I have highlighted in red color over here, these are the ones which are currently available under the National AIDS Control Program, free of cost to all patients who are registered at the ART centers in India. So as far as when to start ART is concerned, so there has been a lot of change in the guidelines over the years, starting from 2004 when ART centers were first established in India. As of the latest memorandum received from the Government of India in 2017, the advisory is to start treatment for all patients with HIV on ART as soon as possible, regardless of their CD4 count or clinical stage at presentation. So in order to start treatment, first we need to make a confident diagnosis of HIV. Now, HIV diagnosis is not as simple as getting a blood test for a hemoglobin. It has a lot of social, economic, cultural implications. So a lot of counseling, taking consent of the patient, confidentiality to the patient, getting the correct test results, and after a person is tested positive, to connect him to services for HIV care becomes very, very important. Since India is a low prevalence country as far as HIV is concerned, like I mentioned before, we need not 1 but 3 tests in order to confirm and make a confident diagnosis of HIV, for which we use ELISA or rapid tests. At AIIMS, we use these 3 tests, the COM-based, TREDRO and Meriscreen, which are immunoassay based tests, with the first test having a higher sensitivity than the other 2 and the other 2 tests having a higher specificity. This testing is done in the Department of Microbiology, HIV lab under Professor Bimal sir. Indeterminate results, if at all we encounter them, the sample is tested, a repeat sample is taken after 2 weeks to confirm the diagnosis. So diagnosis needs to be made carefully and confidently because it has a lot of implications. Once a diagnosis is made, pre-ART, a thorough workup is very essential, including a detailed history, a thorough clinical exam, and most importantly, to look for opportunistic infections, especially tuberculosis, and also to screen for high-risk behavior. So all this becomes very important before we jump to starting ART. And we also get certain baseline investigations done, like the complete blood count, liver, kidney function tests, the baseline CD4 count, to look for co-infections like hepatitis B, hepatitis C, to rule out tuberculosis most importantly, and other additional tests as per the case-by-case basis. For this purpose, the samples are collected at the ART center itself in room number 14 for CD4 count, viral load and HIV ELISA. Other samples are collected at the central lab. Non-availability or non-feasibility of any of these tests should not delay the initiation of ART as per the mandate of the Government of India as well as the WHO, which strongly advises starting ART within 7 days of diagnosis. Before starting ART, like I mentioned earlier, an informed consent counseling apart, we also need to identify a caregiver in the family who can monitor the therapy of these patients and ensure that they take their medications regularly. Also, if at all any opportunistic infection is detected while screening, then cotrimoxazole and isoniazid prophylaxis need to be started based on the advice of a physician. So, as far as the treatment is concerned, the WHO has updated its recommendations in 2019 and again now in 2021 with regards to first line and second line ART regimens that are to be followed. So, what is strongly recommended is a first line regimen consisting of 3 drugs, tenofovir, lamivudine and dolutegravir, and in situations where this cannot be used as an alternative, efavirenz can be used in certain special situations. And in case the patient does not respond to first line regimen, even then the WHO and NACO have provided options how to switch from first line therapy to second line therapy based on what medication the person was receiving in the first line therapy. So all this is done at the ART Plus centers at AIIMS, and NACO has updated guidelines in 2020 to include a fixed dose combination of tenofovir, lamivudine and dolutegravir as the first line therapy, even not only for treatment but also for post-exposure prophylaxis. And once we've started a patient on treatment, it's very important that we monitor them for response to therapy. So we look at the clinical parameters in terms, we expect the patient to become asymptomatic within 12 weeks of therapy. And we also monitor the CD4 count and viral loads at regular intervals at our ART center. And we expect a rise by 50 cents per year and a viral load to become undetectable as soon as possible. And this is monitored on a yearly basis at our ART center. And while we are monitoring, it's also important to screen for tuberculosis, any adverse drug reactions, any drug-drug interactions, and also to assess the treatment adherence. It is a lifelong treatment and requires a team approach to be successful. When it comes to ART center at AIIMS, it was established in May 2005, and it is designated as an ART Plus center. It receives its financial and logistic support from NACO through the Delhi State AIDS Control Society. It works 6 days a week with 9 a.m. to 4 p.m. on Mondays to Fridays and 9 a.m. to 1 p.m. on Saturdays. It is manned by the nodal officer, who is the head of Department of Medicine, Professor Naveed Vaik sir, one senior medical officer, Dr. Sanjay Ranjan, and 2 physicians at any given point of time, usually a senior resident and a junior resident. Also, there are staff who do invaluable work there, the lab technician, the pharmacist, the nurse, ART counselors, data managers, and the community health worker all work together to make this a successful venture. So just to give you an idea, when a patient visits the ART center, they're first directed to the ICTC, which stands for Integrated Counseling and Testing Center, which is in room number 5, where the patient is counseled even before the HIV testing is done. Then subsequently, the sample is taken for HIV testing, and if the patient tests positive, post-test counseling is also provided in detail, where the patient's concerns, queries are addressed patiently by the ART counselors in room number 11. Also, the patient is registered for ART in the future. Then the patient is directed to the physicians who are located in room number 10 or 12, who do a thorough pre-ART evaluation, get the baseline tests done to check the immunological status and rule out opportunistic infections. After that, if the patient is found suitable to start ART, remember all this has to happen within 1 week of diagnosis. Then once if the patient is found suitable to be put on ART, the treatment is prescribed by the doctor. And once again, the patient consults the ART counselor, who tells him about the importance of drug adherence and lifestyle modifications. Then the patient's case history and details are recorded on a file, and the care coordinator maintains the patient's records. Finally, the patient receives his ART drugs from the pharmacy, which is located at room number 7. All this happens within the ART center. And after that, patient is advised to follow up on a monthly basis to collect his medications. In case the patient gets lost to follow up, then there's an NGO which AIIMS has tied up with, which is called DNPP, that is Delhi Network of Positive People. So this organization is helping us currently to trace these patients who get lost to follow up. So this is a wonderful system which has been working for decades now at AIIMS, and we have managed to help thousands of patients. So now, to tell you more about our experience of the ART center here, I invite Dr. Devashish to tell you some hard data about what we've been doing the past few years.
Thank you, sir. So in this next segment, we will be discussing some basic descriptive data of patients who were enrolled at our ART center in the period between April 1st, 2015 and March 31st, 2021. So in this period, a total of 4,702 HIV positive patients were enrolled. Out of these, 97% or 4,556 were newly diagnosed, that is, they came to us for the first time, while 146 were transferred in from other ART centers from other parts of the country, out of which 143 were already on ART when they were transferred to us, and 3 were transferred before the initiation of ART. Here you can see a graph which depicts the year-wise number of patients enrolled at the ART center, stratified by gender. You can see that between 2015 to 2018, the number of patients enrolled gradually increases, but then this number steeply declines in 2021. And again, this is probably attributable to the COVID pandemic, because of which patients were not seeking routine routine medical care. The mean age of this cohort is 34.7 years, standard deviation 12.6. Our youngest patient is 1 year of age, and our oldest patient at the time of enrollment was 79 years of age. Around 68% of patients were male, around 31% were female, and 11 patients in this cohort identified themselves as either transsexual or transgender. Here you can see the distribution of age and gender of this cohort. You can see that most of our patients fall in the reproductive age group, with more than 2/3 being male. We also have a small but significant fraction of patients below the age of 15 who are also receiving ART. Now, the state of Delhi contributes around 32.3% or 1519 patients in this cohort. But Delhi is not the leading contributor of patients in this cohort. Most patients actually come from the state of Haryana, which contributes 39%. That's mostly Faridabad and the Palwar belt. The state that contributes the third highest number of patients to this cohort is Uttar Pradesh with 18.7%, and the fourth is Bihar with 6.1%. These four North Indian states together comprise 96% of this cohort over a 6-year period. The remaining 4% are divided from different parts of India. But then again, it's just these 4 states that we mostly cater to at the ART center. Now, out of these 4,702 patients, if we exclude the 389 for whom data is missing, we'll find that 73% of the remaining are married, 2.9% are widowed, 0.7% are divorced or separated, 15% are single, and 0.1% are in a live-in relationship. Here you can see a tabulation of the mode of transmission of the patients in the cohort. So for 9.3%, we don't know what the mode of transmission was. But usually this is because the patients are not forthcoming about their history when they come at the start. 81% acquired the infection most likely through the heterosexual route, which is consistent with the national data. The second in our cohort is mother-to-child transfusion at 5.1%. MSM officially accounts for 1.2% of all transmission, but this is again likely an underreported figure because patients are usually not forthcoming of this kind of history. Here you can see the monthly income distribution of the patients who are enrolled in the 6-year period. So you can see that most patients belong to the poorest of the poor category with an income less than 5,000 rupees a month. Again, usually you have poor patients that come to the government for treatment, but also HIV as a disease disproportionately affects those that are disadvantaged. Here you can see a tabulation of the occupation of the people in this cohort. The most common occupation came under the category of semi-skilled work, which is a broad category which encompasses different types of labor. That's around 48.3%. You'll find that housewives are an unfortunate casualty of the HIV pandemic, contributing 23% of the entire cohort. Transport workers, including truck drivers, which are traditionally considered a risk group for HIV, are just 0.8%, as are agricultural workers, especially those who migrate from other states to work in the fields. In our cohort, they comprise just 1.5%. So when patients come to the ART center for the first time, as a part of the pre-ART workup, their baseline CD4 count will be done. And this baseline CD4 count gives us an idea of the functional status of the immune system at that point in time. So in general, if a patient comes, the earlier a patient comes, the higher the patient's ART, the CD4 count is likely to go. So you can see that about a fifth of all our patients come with a CD4 count more than 500. Around 40.2% come with a CD4 count between 200 and 500, while the remaining 40% or so come in stage that is known as AIDS, that is a CD4 count less than 200. So with this data, we decided to see, year-wise of all the new patients who are enrolled with us, what proportion of them came to us with a CD4 count less than 200. You can see that between the years 2015 and 2018, this proportion remains roughly the same, between 30 to 40%. This gradually increases, especially in 2020. And again, this is probably attributable to the COVID pandemic. Again, people are not seeking routine medical care. So the people that come to the attention of the medical services are those that are sick. And those are the ones who are likely to have a CD4 count less than 200. Now, out of these 4,702 patients, 790 never made it to the stage of ART. So in that period, 67 died, 443 were lost to follow-up, 29 opted out, 185 were transferred out, while 66 were not started on ART. This is in the period prior to 2017 when test and treat was started. So finally, we have 3,912 patients who were started on ART. Now, these are the outcomes as of now of these 3,912 patients. So around 70% are currently alive and doing well on ART, which is consistent with the national data, although our target here is more than 90% ideally. 5.3% have died, 11.8% have lost follow-up and or were transferred out, and 1.3% opted out. Now, if we take these two cohorts, that is those that are alive and those that are dead, we decided to look at baseline CD4 count as a marker of prognosis. So you can see that those that died as compared to those who are alive had a higher odds of having a baseline CD4 count less than 200, an odds ratio of 3.8, confidence interval 2.8 to 5.1 with a significant p-value. Similarly, of all these patients, most of them had an increase in their baseline CD4 count after ART initiation, while a small number had a decrease from baseline CD4. And this is either because of poor drug adherence, malabsorption, drug interactions, or ART resistance. So you can see that those that died as compared to those who are alive had a higher odds of having a decrease from baseline CD4. So this just demonstrates something that we already know, that the CD4 count is the most important marker of prognosis ultimately with HIV patients. You can see that the most common regime currently that people are receiving is TLE, that's at 42.6%. However, since the last year and a half or so, we have been transitioning patients to the new recommended first-line regime, that is TLD. Currently, around 33% patients are on TLD, while the remaining quarter of the entire cohort are on other regimes, either alternate first-line, second or third, or pediatric regimes. Now, every time when a patient comes for their monthly or 2-3 monthly visit, we always assess the adherence to ART. So if less than a single pill is missed in a month, then that means the patient has an adherence of more than 95%. And this comprises around 72% of patients in the cohort. Around 12.1% have a average compliance of 80 to 95%, and 15.5% have a poor compliance, less than 80, which is not desirable because it creates the conditions conducive for drug resistance. And this concludes our data on the ART Center. Now I would like to call Dr. Adarsh, who will be talking about the research done in the field of opportunistic infections as well as post-exposure prophylaxis.
Good evening. Thank you, Dr. Devashish. So now I'll be dealing with the opportunistic infections in HIV. My discussion will be based on the various publications from the Department of Medicine and ART Center in the past years. HIV-related opportunistic infections are those that are more frequent or more severe because of HIV-mediated immunosuppression. In the pre-ART era, pneumocystis jirovecii pneumonia developed in more than 80% of HIV-infected patients, and disseminated Mycobacterium avium complex infection occurred in 30 to 50% of patients with advanced HIV infection. Coming to Mycobacterium tuberculosis infection, PLHIV are nearly 29 times more likely to develop tuberculosis. The annual risk of reactivation of latent TB infection is around 3 to 16% per year. And unlike other opportunistic infections, TB can occur at any CD4 T lymphocyte count. And patients co-infected with tuberculosis are also found to have higher viral loads and a greater risk of HIV progression. This article had compared the early versus delayed initiation of antiretroviral therapy for HIV TB co-infected individuals, and the study has around 150 patients with HIV TB co-infection, and it has found out that early initiation of HART in patients with HIV TB co-infection significantly decreased the incidence of HIV disease progression and had good tolerability. Another study to compare nevirapine versus efavirenz in ART regimens in HIV TB co-infected patients. Basically, efavirenz is costly, nevirapine is less costly, and this study has found out that nevirapine-based ART is a reasonable alternative to efavirenz in resource-limited settings. 284 patients with HIV TB co-infection were studied in this. Another study comparing once daily dose of nevirapine, that is 400 mg, versus twice daily dose in patients with HIV TB co-infection. We know that rifampicin given in ATT can reduce the plasma concentration of nevirapine, and this study has revealed that nevirapine 400 mg OD based ART
combined with tenofovir and lamivudine can be an effective alternative to improve the compliance in resource-limited settings. And here, 120 HIV-TB co-infected patients were studied. This was a landmark study conducted in the Department of Medicine, showing the importance of vitamin D in tuberculosis and HIV. This study has revealed that low levels of vitamin D in serum as well as in the bowel fluid were observed in HIV, TB, and HIV-TB co-infected patients, indicating that a localized deficiency of vitamin D metabolites can be associated with an increased vulnerability to tuberculosis infection. Now, this is a study on TB IRIS, that is immune reconstitution inflammatory syndrome. This study has shown TB IRIS to occur in 5 out of 123 HIV-TB patients, that is paradoxical TB IRIS, and 6 out of 80 patients, HIV patients, they developed tuberculosis while on treatment with ART. Another study comparing the efficacy and safety of thrice weekly drops in TB patients with and without HIV co-infection. It has included 150 HIV positive patients, and this has shown that thrice weekly ATT is more effective in HIV negative than in HIV positive patients. This was another study, that is cryptococcal antigenemia in advanced HIV infection. So this study has shown that cryptococcal antigenemia is common among patients with CD4 lymphocyte count less than 100. And cryptococcal antigen should be measurement should be made as a routine practice in PL-HIV with CD4 count less than 100. Now, another study, that is the prevalence and evaluation of risk factors of ART failure among HIV infected patients in North India. In this, we have the opportunistic infections. The most common opportunistic infection was tuberculosis, and among which extrapulmonary tuberculosis was more common than pulmonary tuberculosis. And the total patient study were 301. Now, in the same study regarding cryptococcal antigenemia, this has come out with the various spectrum of opportunistic infections among the recruited patients, among which oral or esophageal candidiasis was more common, which was followed by tuberculosis. And among tuberculosis, extrapulmonary tuberculosis was more common than pulmonary tuberculosis. Another study, the outcomes of antiretroviral therapy in Northern Indian urban clinic. Here, the WHO clinical stage 3 events were the most common, followed by the clinical stage 4 events, and the total study population was 631. Now, coming to the GI opportunistic infections, studies on GI opportunistic infections in HIV. This is the Clostridium difficile infections in HIV positive patients with diarrhea. So here in the study, Clostridium difficile was found in 12 out of 237 HIV positive patients with diarrhea. And the study had found out that the frequency of infection was more in patients who had received antiretroviral therapy. However, compared to previous studies, our study population had a low frequency of Clostridium difficile infections. And another study on the intestinal parasitosis in relation to antiretroviral therapy, CD4 count, and diarrhea in HIV patients. So this study had revealed the various opportunistic GI pathogens, among which Cryptosporidium and Isospora belli were among the most common GI opportunistic pathogens among the 200 HIV positive patients studied. This was another interesting study regarding the prevalence of Epstein-Barr virus DNA among the HIV positive individuals with and without malignancies. So this study had revealed a high prevalence of EBV, that is 30% among the 92 specimens tested, and the prevalence was higher in patients with malignancy when compared to patients without malignancy. And another study regarding the neurological opportunistic infections. The study was based on magnetic resonance spectroscopy of brain, has revealed 14 patients with CNS tuberculomas and 4 HIV patients with progressive multifocal leukoencephalopathy. And coming to progressive multifocal leukoencephalopathy, that is PML, this study, it was an observational study, and out of 1,465 patients with HIV/AIDS, 18 were diagnosed with PML. And the study has revealed that PML is associated with high morbidity and mortality despite the initiation of highly active antiretroviral therapy. We know that malignancies are also common in HIV. So this study has, that is the prevalence of malignancy in HIV as well as HIV in malignancy. Among 999 HIV positive patients at the ART center, the malignancy prevalence was 2%. And the most common malignancy was non-Hodgkin's lymphoma. And here the study had shown that AIDS-defining cancers, they are much more common than non-AIDS-defining cancers. However, with the increasing use of ART, it is expected that non-AIDS-defining cancers will increase in number. Now, another study, that is cognitive performance and neurometabolites in HIV using 3D magnetic resonance spectroscopy. So this study had revealed that impairment in at least one cognitive domain was present in around 32 patients, that is 74%. And so there is a high prevalence of cognitive impairment in ART named patients with HIV. Okay, now I'll just brief on the prophylaxis of opportunistic infections as per NACO. We give quatramoxazole preventive therapy for all PL-HIV with CD4 count less than 350 or WHO stage 3 or 4. And isoniazid preventive therapy is given for all patients with latent TB infection, that is after ruling out active tuberculosis. And for patients with CD4 less than 50, we give azithromycin weekly prophylaxis for the prevention of disseminated Mycobacterium avium complex infection. Now we know that hepatitis B, C co-infections are also common in HIV. So this is the data from the ART center. Among the total 4,702 patients from April 2015 to March 2021, there were 59 hepatitis B virus HIV co-infection and 63 HCV HIV co-infected patients. And this study was previously quoted regarding the prevalent evaluation of risk factors for ART failure. Now, this study has also revealed among 301 patients, 10 cases of hepatitis B and 6 cases of hepatitis C. And this study, which was previously mentioned, now this is coming to the comorbidities in HIV. And this study has revealed several comorbidities in HIV, among which renal disease was most common. And these are some of the recently completed theses by the residents in our department. And they have, these studies have also revealed hypertension, diabetes, hypothyroidism, coronary artery disease, etc., among the various comorbidities in HIV. Now, another study from our department, that is HIV-associated renal disease pilot study from North India. Renal involvement was found to be common in HIV-positive patients, and that was around 17.3%. However, the low occurrence of renal involvement in HIV patients already on ART suggests some of the renoprotective effects of antiretroviral therapy. So that was regarding the publications in opportunistic infections. Now I'll have a short review on the data from the post-exposure prophylaxis. Now, post-exposure prophylaxis, or PEP, is a short course of anti-HIV drugs given in an emergency situation, that is soon after a possible exposure to HIV in order to prevent HIV. However, it is not 100% preventive. Who are eligible for PEP? Occupational exposure, that is healthcare workers, sexual assault victims, injection drug users, and unprotected sexual exposure. However, the NACO recommends PEP for the first two groups. The PEP begins with assessment, that is assessment of source and exposure risks, and baseline HIV testing for the exposed person and source can be done whenever possible. And eligibility of PEP is decided. And after that, counseling is given regarding the risks and benefit of PEP. And after taking PEP, counseling is given for adherence. From the data from the ART Center, from 2015 to 2021, there were 586 recipients of post-exposure prophylaxis. And among this, 60% were the healthcare staff, and 40% were the remaining. And among the healthcare staff, the most common were staff nurse and junior residents. And these are the various modes of exposure. As expected, needle stick injury account for 65% of the exposure, and this is followed by sexual assault, that is 11%. And this is the zero status of the possible source of exposure. 367 out of 586 were confirmed HIV positive, whereas 185 had a status unknown. Now, PEP prescription, it is started as soon as possible, that is ideally within 2 hours, but not beyond 72 hours. And PEP initiation should not be delayed for the HIV report. And after getting the HIV report, if it is negative, PEP can be discontinued. And the regimen selection is age appropriate. And this is the data on the duration between the day of exposure and starting of PEP. 93% of the recipients, they received PEP within the 72 hours. However, 7% received after 72 hours. These are the PEP regimens. The current NACO guidelines recommend tenofovir 300 mg with lamivudine 300 mg and dolutegravir 50 mg, one tablet once daily for 28 days as the regimen. We have alternative regimens including tenofovir with lamivudine and ritonavir boosted lopinavir, as well as tenofovir lamivudine with efavirenz. So with this, I am completing my discussion. Now I hand over to Dr. Anivita to discuss on HIV drug resistance. Thank you.
Good afternoon, everybody. Thank you, Dr. Adarsh. Now we shall be heading upon HIV drug resistance. If you look at the chronology of any patient who is having ART failure, the initial manifestations will be in the form of increased viral load, followed by immunological failure in the form of fall in CD4 count, followed by a clinical presentation which might be too late before we actually detect HIV failure. So ART failure can be defined according to WHO as the new or any recurrence of a clinical stage, WHO classified as 4, after 6 months of effective therapy. 6 months of effective therapies has to be ensured before we determine that any patient is having ART failure. Immunological failure, whereas, is referred to as when CD4 count falls below that of the pre-treatment value, or if it persists to stay below 100. Similarly, virological failure, as per WHO and NACO, is defined as viral load of more than 1,000 copies after 2 consecutive testing, 3 months or 6 months apart, with effective ART regime. Whereas the international guidelines actually have a more stringent criteria of failure defined as less than 50 copies or less than 200 copies. Now, the reasons for ART failure can be multi-pronged. They can be ranging from non-adherence due to either the patient is suffering from depression, or he's having substance abuse, or the timing or the pill burden is increased. Or it could be because of poor absorption. Poor absorption may be because of multiple drug interactions with the other opportunistic infections or the comorbidities that the patient is having, the poor medical condition, gut parasites, and one of the important aspects is drug resistance itself. So the burden of HIV drug resistance has been found all over the globe. However, in Indian subcontinent, it's not been well studied, and the prevalence as of now is much less as compared to the other continents. In this Stanford publication, where they had collaborated all the HIV drug resistance all over the world, we find that in the Asian subcontinent, the prevalence is 3.2%. However, in other states, it ranges from 5 to 20%. Now, HIV drug resistance can be classified into primary or secondary. Primary means that the drug resistance has been transmitted from an infected person from where the exposure has happened. And secondary is acquired over time because of accumulation of mutations, either because of poor adherence or because of the poor absorption of the drugs. Now, the methods to determine can be either phenotypic or genotypic. However, they require a prerequisite where the viral load has to be above 1,000 for the tests to be valid. Phenotypic methods are very cumbersome. They basically are tested by growing the virus in different concentrations of various antiretroviral drugs, and the conventional methods often take up to 4 to 6 weeks. These are not easily accessible everywhere, and hence they are difficult to obtain. The the usually used method is the genotypic method, which can either be performed by commercial kits or it could be developed in-house. So here the turnaround time is much faster and it has much lower cost. All the mutations that are present in the viral genome are detected. They may or may not be actually conferring resistance. Hence, the interpretation has to be very carefully done. So the interpretation can either be done by an expert who's aware of the in vitro and the in vivo data and has updated synthesized methods where all the phenotypic and genotypic methods are correlated, or it can be done via the databases. These databases are freely accessible. The most commonly used is the Stanford Drug Resistance database, where we can enter the mutations that we have that we see in the genotype report, and the new regimen can be constructed depending on the various drug interactions and the interpretation. So if we look at the private labs, the Lalpath and SRL labs actually do genotypic testing in about 20,000 rupees. They include NRTA, NNRTS, and protease-based inhibitors. However, if we want to do genotypic testing for INTIC-based inhibitors, that needs to be added. The genotypic testing that is done in our department is virus sequence by Abbott, and we had performed various studies over this. So when we looked at the ART naive population in northern India, among 68 individuals, we found that the prevalence of ART drug resistance was 2.9% in our cohort, which comprised of NRTA and protease-based inhibitor resistance both. And among individuals who had first-line failure, this is about 128 patients, 93% patients had NRTA and NNRTA resistance, and over 10% individuals also had protease-based resistance. It is interesting to note that when results were tabulated for patients who had co-infection with HIV, it was found that the prevalence of ART drug resistance was higher than that of patients without any co-infections. So here, the drug resistance among patients with HIV-TB co-infections was almost 13.3%. And when we looked at first-line ART failure, here also the HIV-TB co-infection had much higher drug resistance mutations found as compared to that of without co-infections. Now, this table summarizes all the studies that have been done all over India for HIV drug resistance. Here we can see that in Delhi, from our cohort, we found prevalence about 2.9 to 7.5% in the ART naive population. And similarly, in rest of the country, the prevalence ranges from 3 to 10%. However, in the cohort of HIV-TB co-infection, the prevalence is maximum, which is 13.3%. So it is important to note and understand that ART drug resistance is rapidly increasing, and because of poor accessibility of these tests, HIV drug resistance is often missed. This leads to delayed presentations of opportunistic infections and increases mortality and morbidity amongst these individuals. Now, NACO has proposed introduction of pre-exposure prophylaxis soon in our under the program. This would ensure that for patients who are high risk, such as commercial sex workers or serodiscordant couples, they'll be provided with pre-exposure prophylaxis for prevention of acquiring the disease. One of the difficult to treat co-infections is HIV and HCV. This includes a lot of drug-to-drug interactions, poor accessibility to genotypic testing and viral loads, as well as the drugs are very difficult and very expensive to procure for general population. NACO is soon to introduce the HIV HCV co-infection into the program, and it will be easier for the patients to be able to follow up for this co-infection. The need of the hour is to introduce drug resistance testing, as we just discussed that this is often missed, and right now we have first line and second line therapy based on empirical treatment. Once HIV drug resistance is easily accessible, we may be able to individualize the patient's regime, and the patients might be able to switch easily from a failing regime to an effective therapy. So to summarize, we know that around 40 million people are currently living with HIV and over 2 million are in India. And our ART Plus Center, which was established in May 2005, is catered to over 10,000 patients as of now and has led a battle against HIV since then. We just presented the descriptive data of about 4,700 patients, which is comparable to our national data. The recent introduction into the NACO program of dolutegravir has not only increased the tolerability to the ART program amongst the patient, but it also increases the barrier to resistance, hence the therapy is likely to be more effective. TB is obviously the most common opportunistic infection, but we have to keep a very high index of suspicion for other rare pathogens as well, which have been found to be very common in our cohort. Post-exposure prophylaxis must be accessible to the exposed individual within 2 hours and maximum up to 72 hours following the exposure. The COVID pandemic has actually hit the enrollment and the follow-up of patients in 2020, and we hope to seek better care in 2021 for these patients via teleconsults and via awareness. One big challenge that we are facing is emergence of drug resistance testing, for which accessibility of drug resistance testing is important. But the most pivotal role that we as residents and as doctors can provide is ensuring proper good adherence, which can never be overemphasized. So now I would like to invite Professor Sinha sir to conclude and provide remarks for acknowledgements.
Thank you very much for excellent presentation. We try to include most of the things which are possible in limited time. And I would like to thanks to following person for support to PreART Center and HIV program at AIIMS. First of all, I would like to thanks Professor Vic. He is involved in the HIV program since beginning. When I was senior resident, he was involved at that time in HIV treatment of HIV program, HIV patient. Then I would like to thanks to the faculty members from Department of Microbiology, especially Dr. and Dr. Professor Das, and all the faculty members from the Department of Medicine. I would like to thank to Dr. Pandey for analyzing the data for this CGR, and then all the residents of Department of Medicine and infectious diseases. And also would like to thanks to the staff of the ART Center, including Dr. Anjan, and staff of the Immunology Lab, HIV Lab, and Virology Lab. And a special thanks to National AIDS Control Organization and Delhi State AIDS Control Society for providing the funding for ART Center. So now we just ending here, and we can have question and answer. I would like to request to Professor Vic for his comments, and then we can have question and answer. Thank you. Yeah, please.
So, how medicine is learning, you can learn from it. And how the politics is done. What is the So I joined the AIIMS in 1997. So there was nobody looking after it. Nobody being suited. Open hardware used to be there. Then one day he said, what is HIV? Because there was controversy and something. There was nobody looking after it. That is how the first part of this happened. And then what will happen is, so only HIV patients are so now there will be only we treated them without drug resistance. There was no HIV. HIV came in 2005. HIV came in 2004. Was founded in 2005. HIV came in 2004. What was happening between 1996 and 2005? These patients were so sick, they were also causes CML, mortality. Everything was there, and then now for the long time was not easy. When I had to give my first talk, I had to study for 50 months. But there was no drug available. So you have to learn to be self. You have to learn to be selfish. We have to learn to be selfish. When we admit patients will know, nursing will be afraid. There will be no isolation bed. They will take it. And you never know who they are. So the main issue was then there was a study one day in January, the 20th. There was a staff who came to what to do. So then we get one small study. Alright, we collected data the same night. Next day there was CCR. So that was the type of intensity that is required. Today you are sitting here, you are working for it will be after 25 years, you will be seeing the obscenity which has happened now. Maybe the last 3 years, but I said, but not only the only thing you have to that is the kind of solution. To remember and say they will actually probably become such a block created on the all guided by your home isolation, policy, this policy, that policy, you are made, all videos you are made. That's how you say they get it. But you will remember this and you will be unbelievable. So then what happened was, if it is study, consult of that and availability of processor. So now there is a Preexposure Prophylaxis 1987. I thought it was they were just the incineration. So then there were concerns of but availability and volume. So then therefore issued an order that 10,000 rupees would be given per staff if relocated to India. So then our study came in that this was to the so now this was to the but what about the writing part of your life? That's all available. Comment market. Then the in 2004 we had started there were 6 centers. Today how many centers are there? 550 plus 1,000. So things evolve, they take increase your patients. And it will be very expensive. But suddenly the global thing happened, everything was being available. Then the first line everything was SIPA. So SIPA and multiple companies by those but 6 centers. From 4 states we get the patients from 6 centers. So and then the once I asked you if you get it, but I didn't know what to do. So when after 6 months of 1 year, we went to Then the calculator ratio came when we decided to be now. So in 2004, these were there into later. So always there some jealousy. So this is one aspect. So you have to take on first, only then you can recommend. That is why we didn't go to the healthcare person concerns. Number one, it is everything secondary. So healthcare worker concern is most important. So then what happened was they are taking tuberculosis. Tuberculosis from day one we are saying after 2 weeks of writing, do this. Severity we started from day one. Came on day one. Opportunistic infection guidelines are made by us. Till today they have not been changed. Because maybe I don't know where medicine. 2007, today is 15 years. Nobody knows. How to treat also, how to used to treat. 16th of September, without CPM, full as erythromycin, then you have to treat with the particular. So, so that problem is essentially one would be like and then the mother to child transmission. Imagine mother to child transmission was being treated with single nevirapine. They will give one tablet to mother, they will give one tablet to the child. This is how mother to child transmission. How they get treated. How mother gets treated. Now the child is getting one. But to child, to the infant, they are still not able to grow. For mother, they will give birth. So, more is using brain. It is all the circulation. Medicine is some studies will come and go. Hospital may have listed 2.5 years to add person. So the development we added from day one, the reactivity we added from day one, mother to child transmission. We forced them to start. From the development, this is what is maybe in 2011, 12, in 2015, it was so many years of bring mother to child transmission. It was an excellent presentation, one of but there are a lot of hidden things which are there in this. But we have to learn to be we have to live this. But concerns of healthcare workers are most important. And there are concerns of the patient. Healthcare workers are very good patient. Then they will be high. That is what else was. Every day there is been for the last 15, 20 years, how to manage a few topics which are most important for education. Informed consent. Informed consent is most important. Second is confidentiality. Confidentiality of the patient. Third is stigma and discrimination. You cannot stigmatize, you cannot discriminate anyone. Because people, then we have bias, we have this one from others. There are rumors, so that is why we got into their mind that these are the concerns of healthcare workers, these are the concerns of patients, these are the concerns of today, if you want to treat If you want to treat HIV, after you start now, what? There is different treatment for life now. No single treatment. It's not a single treatment. Don't take this message in very sense. Very long, you are very many and the virus will remain suppressed. It's simplified disease. One treatment, no best lifelong. This has become such a simplified disease. That nurse was the general Acknowledgements. This is the cost of this is because so we were taking some room to buy from to buy from there and get some name of money. So he was willing to do anything to give me the work from there. So that was the idea. But you have to get it, you have to get it. You have to get it from the program. That is how that is why
Do you have any question?
So I like to compliment that part. So beautiful. It's really very good. Another question was just kind of something to speak on. The secret presentation was that the co-infections, more infections, and then the other way around, patient was resistant to drugs. They are looking for this.
So we have done the two studies. We have done one study in HIV patient without any co-infection, and that was showing about 2.9% primary drug resistance. Another study in the same group without any co-infection, we have seen patients who have followed about 4 or 5 years, and after that they are getting value that was kind of high drug resistance. And another study that was done with co-infection with TB, where we found primary drug resistance was around 7%, and follow-up in the follow-up resistance was more, and most common mutation was M184B in both the studies. That was our. So your question is in the co-infection, we found more, and what is the other point you raised?
I was just thinking that the persons were already resistant to drugs.
Yeah.
They didn't know for these things.
Yeah. So that's why if patient have already resistance at the baseline, if they are having primary drug resistance, then we have around 3%, and they are prone for, since beginning they are not responding to antiviral drugs, so they are already in failure, so they can get the more opportunistic infection. Any other question?
That resistance should not happen. That resistance should not happen. And these drugs are very simple. Otherwise, we used to get them that way. 6 packets of that 2 packets of that. And everybody was signing was to be given. We used to give them Dana was 400 milligrams. 4 capsules twice a day. Is 4 plus 4, 8, right? 8 plus 6, 15. It was twice a day. But there is a lot. And where you get 4 doses of medicines, this probably minus of idea. Otherwise, I don't think I they want a condition. So, very important. Because these are the these residents in South making HIV patient will be able to get it be a because will be so what was planned was that this treatment should fit in their routine. This is for every treatment. That treatment should fit in patient's routine. There are many issues, but it is not so much that it will make you that is why I request patient care इतनी करोगे मेडिकल वेबसाइट पे वही सब कुछ है बाकी किताबों में पढ़ना देखना ये सब कुछ नहीं सबसे ज़्यादा स्टूडेंट लिखूं डिसाइड है बिलियन डॉलर ऐसे बिल्कुल तो सेकंड इंडियन
Dr. Das would like to say, and any other faculty member you want to say.
I wanted to highlight that our HIV lab is in both Department of Microbiology and HIV. The sample also the indoor takes an individual sample by the infection department for this should also come to us, but some of these samples actually go to a different section like dermatology, etc. So because we have a centralized narrow research guidelines, we have been accredited from 2012 onward. So this is quality lab. That's all I like to emphasize. Only issue that we have not followed up because it includes confidentiality, so reporting was we avoided getting into the online, but I think there is a suggestion.
Yeah. Any other? Okay. Okay, Doctor. Thank you very much, Doctor. Any other question?
And I want to thank Dr. Sanjay Raghavan. He has been there for last 6 years. So I now learn. So that is how the system is. Sometimes if you are not that much needed.
Thank you very much. Thank you and have a good evening.